All right, students, welcome to the Chapter 4 lecture. We're going to start in this discussion with really defining what a drug is. We were talking about in our discussion board post this week, asked each of you to pick a drug out and kind of define what it is, what it does, and kind of where you got your information. And for the most part, you guys did an amazing job. I was very impressed with how thorough you were with your answers. Some of you very creative with your answers, and I appreciate that. It makes for much more entertaining reading. But let's define a drug. And a drug is any chemical or substance that you take into your body that changes how your body functions. Okay. Most of you who wrote on caffeine were reported that you were surprised to see that this was actually considered a drug. And since it certainly changes the way you function, as it increases things like blood pressure and respiration, it's either a vasodilator, which means it increases the diameter of the blood vessels in the body, or a vasoconstrictor, where it constricts the blood vessels, which affects things like heart rate and respiration, blood pressure. Heart's got to work harder to pump the same amount of blood through the blood vessels and the veins. So a drug is anything that's going to change how your body functions. Caffeine is certainly the most prevalent. Oddly enough, if you want to take a guess, and I'll give you a quick second here to think about this, what are the top 3 most abused substances? And I'll say abused, I'll emphasize that word, in the United States today. Okay, the top 3 most abused drugs in the United States today. Okay, number 1, caffeine. Number 2, alcohol. Number 3, nicotine. And as you might have guessed or been aware as I'm saying those, all 3 of those are legal substances. They're drugs, and they're abused because we ingest way too much caffeine, alcohol, and nicotine when we use these things. We don't take them as directed or as moderated, and we do things that kind of degenerate our body and are harmful to our health. You'll also notice all 3 of those products are made here in the U.S., which is no reason, it's no coincidence why they're legal here, by the way, because they're U.S.-made products. There's 5 schedules of drugs that I want you to be aware of, and you will need to know this information. Schedule 1, narcotics, and I'd like you guys to look this up somewhere. There's a wonderful, on the U.S. Department of Justice website, so you can go to, I believe it's deadiversion.usdoj, Department of Justice.gov, and look for the Schedule of Controlled Substances. I'd like you to read through that if you can. But a Schedule 1 controlled substance is any drug that has no currently accepted, and that's the key word, accepted medical use in the United States. It's a lack of accepted safety for use under medical supervision and a high potential for abuse. So, Schedule 1 controlled substance, according to the government, no accepted medical use and high potentiation for abuse. And some examples of this drug are ecstasy, peyote, marijuana. I'll get to that in a second. And I can already feel some of the eye rolling going on here. Heroin, LSD, things like that. These things are not accepted medical use. Now, I'm going to throw this out there that, yes, there are studies out there that show that medical marijuana does have accepted and medical use in the United States. You know, chemotherapy ravages your body, does a lot of damage to your body. Is for every bit of good it does, eradicating cancer. It does a lot of other things where it erodes tissue and can be very damaging. It kills your appetite, and marijuana certainly is an appetite stimulant, and people use that to help not lose so much weight when they're going through things like chemotherapy. It certainly kills pain, so people who have glaucoma or chronic pain have been prescribed medical marijuana in states that have accepted it. The key word here is that is accepted medical use, and the government, the federal government, not the states, the federal government who has these schedules and controls these schedules of narcotics and drugs, has said that we don't have enough sufficient medical evidence to say at a federal level that we change this from a controlled substance, a Schedule 1 controlled substance. So it's still on the list, marijuana is, as a Schedule 1 drug. Okay. A Schedule II controlled substance still has a high potentiation for abuse, very high, which can lead to severe psychological or physiological dependence. And we'll talk about the difference between psychological and physiological dependence in a moment. Some examples of controlled II substances are things like diluted methadone, Demerol, oxycodone, Percocets, fentanyl. I'm trying to give some examples of drugs that you might know. Morphine, opium, codeine. You'll notice that some of those do have some accepted medical use, but we have other drugs that work better that don't have the high potentiation for physical dependence or psychological dependence. Okay, a Schedule III controlled substance is any substance in the schedule might have a potential for abuse that's less than Schedule I and Schedule II drugs, so a moderate potential for addiction, and may lead to a low or high physical or psychological dependence. And some examples of these drugs, and these are certainly controlled substances: Vicodin, Tylenol with codeine, Suboxone, things like that. A lot of the painkillers, a lot of your opiates are in these. Things like ketamine, anabolic steroids. These are things that are non-narcotics. Okay. Schedule IV controlled substance, low potentiation relative for abuse, but gaining much more accepted medical use. They usually have widely accepted medical use and low potentiation for abuse. So things like diazepam, which is also known as Valium, Klonopin, Ativan. Some of you might be familiar with these chemicals. Xanax. Okay, these are all certainly things that have to be prescribed, but they still have a potentiation for abuse, but lower certainly than Schedule I through III controlled substances. A Schedule V controlled substance has, again, widely accepted medical use and low or no potential for abuse, or because these Schedule Vs, for the most part, are not going to produce a euphoric or that really kind of high effect. You don't take them to get high. These are things like aspirin, Robitussin, codeine. Yes, it's certain cough medicines, and the active ingredient in cough medicine that the government's really worried about is called DXM. It's also known as dextromethorphan. It does have psychoactive properties. You'll notice that a lot of stores don't have it over the counter anymore. You have to show ID, and they have it behind the cashier, which I'm all in favor of, by the way. And taken in enough dosage that it can produce some euphoric effects. Certainly not to the degree that Schedule I through Schedule IV drugs are. And the more you have to take to get kind of that euphoric feeling, the more damage you're doing to your body. Because keep in mind, anytime you're taking a drug or any substance, your body has to process it. It's got to go somewhere in your body. And the processing, the first processor that you have in your body is your stomach, and then it goes on to your liver. And your stomach and your liver can only handle so much before it's got to pass some things through, or your stomach's going to shut down or develop ulcers, or your liver's going to develop things like cirrhosis with too much alcohol use, or it's just going to pass these things on through your body, and those are your body's filters. Okay. And that's what could be very harmful to your body, allowing these chemicals to make it through to places they're not supposed to go. All right. Let's talk about levels of consciousness here in Chapter 4. This is certainly very big. So what is consciousness? Consciousness is not just being awake. Okay, it's simply not being awake. That's not enough. It's being aware of external events and internal sensations. I'm aware that I'm awake. I'm aware that things are happening around me. I'm aware of my body's sensations. I'm aware of how I'm interacting with my environment. Okay, and William James, you'll remember that name hopefully from Chapter 1, said that we have what's called a stream of consciousness, that it's not just happening in any one particular moment. It's an ever-flowing chain of thoughts, images, sensations, feelings. And he kind of gave birth to the idea of what we call metacognition. Meta meaning kind of an overarching, and cognition meaning how we think. So metacognition, kind of how we think about thinking, if that makes a lot of sense to you. It sounds like a very philosophical concept because it is. So thinking about thinking. All right, we're going to talk about the different levels of consciousness. And the first one we're going to talk about is higher level consciousness. Very much an alert state. Not that I'm necessarily in danger. I'm just aware of what's going on. It's a conscious process. You listening to this lecture right now, hopefully, is a conscious process. You're thinking about what I'm saying, taking in the information, you're processing it, you're doing something with it, okay? Conversation that you have on the phone with your friend or a text message, those are all active, higher level consciousness processes. It's very controlled. Taking an exam, that's a perfect example of higher level consciousness. You're having to think and use your brain. Have to do with focus. Then we have lower level processing. Okay, this is also referred to as automatic processing. This does not interfere with your other activities or other processes. It requires less conscious effort. You can think of it like daydreaming as a lower level processing. All right. Another lower level processing is, think about you're driving your car, okay, and you're on the phone and you're eating. Think about which of these three things that's going on that you are actively engaged in. Is it eating? Is it talking on the phone? Or is it driving? All right, the correct answer is talking on the phone is your active process, because you're having to think about what the person is saying and responding and having a conversation, and that requires your most of your attention. Lower level processing, you're not necessarily, your body will react to the environment around you, but it certainly does not garner your active attention. The red light happens, so your body kind of processes the fact that you need to hit the brake pedal, the turn signal, looking around, but you're certainly not paying attention to your driving like you should. All right. I'll give you one more example of this because I really want to bring the concept home. All right, you're paying attention to this lecture right now in this video, and that is your higher level processing. Now I want you to change and shift your attention from this video to your feet. Are you wearing shoes? Or maybe even pants? Think about how the material on the pants are touching your skin, or the shoes or socks around your feet. Feel the socks or shoes feel on your actual feet. Okay? That sensation, you can feel it right now, but that sensation you were not actively attending to 1 minute ago. Now you are. Your body still has to do something with that physical sensation. It has to transmit a signal to your brain, has to respond back to your environment. Sometimes maybe you're itching your foot and you're not really thinking about it. That's lower level processing. All right, we're moving on. The third level of consciousness is altered states of consciousness. This is distorted consciousness. Now, this can be produced by either like fever, trauma, drug or substance abuse, medication, fatigue, being overly tired, meditation, illness, any of these things. This can also be an altered state of consciousness, can also be mental health disorders like schizophrenia. Okay, schizo meaning split, phrenia meaning mind. Split in mind, and again, I think I mentioned this in a previous lecture. Having a conversation occasionally with a schizophrenic that's having an episode, they're telling you this horrific story about a train that crashed and 300 people died. And it's really creepy to have that conversation because they're smiling the whole time. Okay, their affect, or what we call, the visual body system that we're looking at, does not match their mood or the story or the situation. That's an altered state of consciousness. Okay. Subconscious awareness. This is kind of like that. We call it waking, because it's kind of that waking moment between dreams and between being fully alert and aware. Your body is automatically processing details that are not really related to active events. So you're not really talking to somebody, but it's doing stuff like the sunlight or maybe the radio or the alarm clock's going off, and you're still trying to make sense out of everything. That's really kind of subconscious awareness. Sleep and dreams. We're going to talk more about dreams as we get on, as it relates to therapy and things like that. I'm not a big believer, if that makes I don't want to turn anybody off right away. I know many of you probably have dream books right now in your house, and that's fine. But as it relates to therapy, I'm not a big person who does a lot of dream interpretation. There are plenty of therapists out there who do, and if it works for you and it works for them, great, have at it. Sleep and dreams are really just kind of an integration of external stimuli during sleep. So we've all had that experience where we kind of fall asleep, the TV's on, and again, there's a crime drama on TV, and we start dreaming about, solving a murder or being part of a murder, or a murder's chasing us, or something's going on with that crime drama, and you wake up, and man, that was just happening in the show. Again, it's because your brain is still processing external stimuli, such as sound or light or pressure or heat, and it's kind of weaving that into whatever dream you're having. The last state is called no awareness. Okay, now this is a Freudian concept, Sigmund Freud, a Freudian concept that he says that this is a storage place for every unacceptable, undesirable, unwanted thought, feeling, desire that we have. And Freud believed that humans have very socially unacceptable thoughts that we have to suppress in the unconscious, okay? And these are things like feelings of incest, desires for incest, things like substance abuse or drug abuse, murder. He's saying that we all have thoughts, not all of those thoughts specifically, but really deviant social thoughts like that we have to suppress, because if we let those out, we'll be shunned socially. So he says this is where we store those things, in the unconscious. A couple of things about sleep. The sleep-wake cycle is also called a circadian rhythm. Our sleep, again, the chemical, the neurotransmitter that helps regulate our sleep-wake cycle is serotonin. You will want to know that. We have biological rhythms. These are physiological fluctuations with our body that rise and fall with our level of hormones. And this is important because it certainly influences our behavior. We become excited, that influences our behavior. We become depressed or irritable or sleep deprived, where those things affect when we have a lack of sleep, are also known as sleep deprivation. We have a lack of attention, focus, depressed mood, higher irritability, all kinds of things. So sleep very much affects our behavior, which affects our interaction with each other. So why do we need sleep? Sleep, as far as we can tell, repairs, restores, re-energizes the body, conserves energy. It's certainly very important in growth and brain development. Okay, our body only has 100% focus, like you only have 100% focus. And when we're sleeping, our body can attend to the needs, the physiological repair and restoration that it can't do when we're actively processing data throughout the day. All right. There are 4 brain waves. I'm not going to take too much time here. This is in your book. I want you to be familiar with alpha waves, beta waves, delta waves, and theta waves. Alpha waves, we're talking about your alpha wave activity. This is kind of how you're becoming relaxed, maybe kind of that dream state, that very early stage of sleep. Waves, our dream waves, become very synchronous and regular. They look like a pattern. Okay. Beta waves, when we're talking about your beta wave activity, your brain activity, as we're measuring it. This is the highest frequency, so the quickest, okay, and the lowest amplitude. Okay, they happen very quick, but they're very short. There's no really consistent patterns because this is when we're attending to different information. Sound over here, the TV's on over here, I have my friend in the background here talking to me, and our attention shifts, so it's not a really kind of a cyclical or patterned type of wave. But that's our concentration and alertness is our beta waves. Delta and theta waves are when we kind of slow things down. Data waves certainly is our slowest and highest amplitude. That's when we're kind of the most relaxed. All right. Talking about stages of sleep. This is very important to understand. And I do want you guys to know these stages of sleep. We have 5 stages of sleep. If you think about kind of a stair down, we go down and then we come back up. So we go down into 5 stages of sleep and come back out through the same 5 stages of sleep. We go through that sleep cycle about every 90 minutes throughout the course of a night, or through whenever you're sleeping. Stage 1 is that very drowsy sleep. We call it myoclonic, or this is when your muscle movements start to fall, your body starts to relax. There's only a very small difference between stage 1 sleep and being very relaxed. If you think kind of like you're in a dentist chair and you're kind of just staring up at the ceiling and you can feel yourself starting to daze, that's really kind of what stage 1 sleep is, really drowsy sleep. Stage 2, you are no longer conscious, actively conscious of the world around you. This is when you have a lot of decreased muscle movement and somebody can be talking to you and you will be non-responsive. Stage 3 is very much a deep sleep. You have less than 50% delta waves. You really won't need to know that for the exam, but just as a point of reference. Stage 4 sleep is a dead weight sleep. And this is where you can kind of pick your arm up and drop it and pick it up. You're a dead weight. That's really all you are at that point in stage 4. Very, very, very the deepest part of sleep. Your stage 5 is what we call REM sleep, or rapid eye movement. So we're going to see people kind of really shift in their eyes. It looks like little windshield wipers are going on. And they're going through, that's where you're kind of dreaming, is your stage 5 sleep. All right. Different sleep disorders that we have. We're going to talk really about 6 different sleep disorders. One is insomnia. Different causes of insomnia can be anything from diet, lack of exercise, stress, being overweight. There's just too many to name. There's tons of different causes of insomnia, but stress certainly is one of the biggest. Stress and diet. Sleepwalking, sleep talking. These sleepwalking and talking occur in stages 3 or 4 of sleep. Probably a few of you listening to this right now are saying, is it true that it's an urban legend that you shouldn't wake someone up in the middle of when they're sleepwalking or they're sleep talking? No, it's not. You're not going to kill somebody doing that necessarily, but it's certainly the urban legend that kind of lends credence to that is the fact that you're just going to put them into shock, really. Taking somebody who's in one state of consciousness and you're going to violently take them out of that and shift them into active consciousness, and the brain really can't process that really actively. So be prepared if you do to deal with a very emotional person in that moment, and that's what the expectation should be. All right, don't expect them to respond really well to that. The best thing to do with anybody that's sleepwalking or sleep talking is just kind of gently just agree with whatever dream they're having, gently put them back and escort them back to bed, and just if you need to keep an eye on them for a few minutes, that's fine. Nightmares. There's a common developmental stage between ages 3 and 6 where kids just start having nightmares. It's very common. If you have a 3 to 6, maybe even as late as 7-year-old having nightmares, they're having a lot of nightmares lately, and you're thinking that, oh my goodness, something is wrong with my child. No, that is very common for that to happen at that time. Your child is going through an enormously difficult change in life. There's a lot of things, a lot of developmental stages they're progressing through, and you'll understand this more as we get into the next chapters. But very common for them to have nightmares or even night terrors between ages 3 and 7. They usually relate to life stressors, things like starting school, discipline, death or loss of a family member. There's a lot of life stressors that can affect children's nightmares, just as they affect ours. Night terrors. Night terrors are less common than nightmares. They occur during non-REM sleep. So they usually occur in stages 3 or 4 of sleep. And the difference is a nightmare, if I'm dreaming that I'm being chased by an axe murderer, and it's a nightmare and I wake up and my chest is pounding and it was a very real experience to me. God, the guy was chasing me and I'm telling somebody else about my nightmare. That's a nightmare. A night terror is the person has no idea. They will not recall the dream, but they usually are screaming bloody murder when they are asleep. And if you wake them up going, man, what was that? You were screaming your head off and we couldn't wake you up. And the guy goes, I have no idea. What are you talking about? Night terror. Okay. Narcolepsy. Any Deuce Bigalow fans out there remember the lady with the long hair that would fall asleep on command? Not really on command, but just kind of randomly. That's narcolepsy. And narcolepsy really is you immediately enter REM sleep. You go from a conscious state and you immediately enter REM sleep. Emotional upheaval can trigger a narcoleptic episode. Narcoleptic episode. Why was that so hard for me to say? I don't know. What we can do to treat narcolepsy and things like that is we can use stimulants, because stimulants help keep your body escalated, and just rather when you go to sleep, rather than this gradual progression into sleep, narcoleptics kind of have a real steep drop off in biological activity. And that's what narcolepsy is. The last one is, most of you are probably aware of this. If you don't have it, somebody you know certainly has it, is sleep apnea. Sleep apnea can cause other medical disorders, and we're not going to get into that, but that's really when you stop breathing at some point during the night. This could be due to diet, being overweight. This can be to, again, lack of physical activity, sleeping patterns. We're getting better at identifying apnea and its effects on the human body and mental health. Most of you have probably either done it yourself, been involved in a sleep study, or known someone who's been in a sleep study due to apnea. All right, a few slides left here. Dreams. Sigmund Freud believed that dreams symbolize the unconscious. So if you were dreaming, if you had a lot of dreams about not getting along with family members, he would probably make an inference that you had problems with your mother, or there was some kind of unresolved conflict with a member of your family. We have two types of content in dreams, no matter what you believe when it comes to dream. There's manifest content and latent content, okay? Manifest content means surface content. So I have, I'm dreaming about a snake, and my dog is eating the snake. And so that's really what I would say. What somebody would say, what's your dream about? And I would say, well, my dog was eating a snake. That's manifest content. Really on the surface, that's exactly what I saw. Latent content means the hidden meaning of the dream behind that symbolism. So that could be, somebody would say, same dream, dog eating a snake. Someone would say, what does that dream mean to you? And I'd say, well, that's the end of innocence. My dog is me, and my innocence is the snake, and I'm really just it's somebody's interpretation of what happened. And again, we'll get into this later on. But manifest is exactly what I see. Latent is hidden meaning behind. Okay? Cognitive theory of dreams. Really what cognitive theory when it comes to dreams, they're studying dreams by using the same concepts that we use to study the mind. Again, cognitive means thinking or how we think. So the cognitive theory states that claims that dreams they're simply just subconscious processing. It's your body's understanding with certain preoccupations or themes. So if you have repetitive themes in your dreams, that a therapist or a cognitive dream theorist might come in and start working with those common themes. What's going on? You're dreaming about death is a common theme and is a common fear with you. Did you lose someone recently, or are you afraid of death? Is there some kind of upcoming event that you're really afraid of? That's what a cognitive theorist would do. Okay? Critics of this theory kind of claim that there's a lack of attention to the actual physical structures in the brain or brain activity that's going on. So there's another dream theory that we're going to talk about called, the last one in here is activation synthesis theory. Activation synthesis theory. This really claims that dreams really kind of result as the brain's attempt to create logic from random brain activity. Me personally, I happen to subscribe to the activation synthesis theory. I really honestly believe, and this is kind of what activation synthesis theory states, that your dreams are a random compilation, kind of like a collage of thoughts, experiences, people you've met, whether you were aware of them or not, things you've heard, movies you've seen, music, family members, common themes, life stressors that are going on. You just started school, or you're afraid that you failed an exam or something, and all of those kind of come together, and your brain's really got to kind of go, all right, I got to try to sort this out in some kind of logical way, and that's really what activation synthesis theory says that dreams are. All right, we're going to talk about a couple drugs real quick. Psychoactive drugs. Psychoactive meaning that the drug has an effect on your mind. It's altering how your mind perceives or functions. Okay, that's what psychoactive means. And then we're talking about depressants. These are all depressants. Alcohol, dextromethorphan. I'll go through these again. Barbiturates, tranquilizers, and opiates. Okay, alcohol. There's a neurotransmitter. We've talked about dopamine, serotonin, and norepinephrine. We've talked about those three neurotransmitters. There's another one called GABA, which is gamma aminobutyric acid. Okay, GABA is a inhibitory neurotransmitter. What that means is there's excitatory and inhibitory. If it's an excitatory neurotransmitter, it's going to make things happen more quickly. It's exciting. If it's an inhibitory, it's going to inhibit means to slow or to stop. So GABA, the more GABA you have, the less activity you're going to get. GABA suppresses activity. Alcohol consumption increases GABA, which slows down your body. People don't speak very quickly when they're on alcohol. They kind of slow down and they move very slowly, okay? So that's kind of GABA at work. Okay? Alcohol reduces your inhibition. Inhibition means your ability to adhere to social protocols. Okay? So I know I shouldn't say that about my friend's mom, so I don't. Have some alcohol, and you will probably say that thing about your friend's mom that you've really been wanting to say and shouldn't. Dextromethorphan, we've talked about this. This is the active ingredient in cough medicine, things like Robitussin or NyQuil. Okay, dextromethorphan is certainly a psychoactive drug. It's a depressant, depresses your system. You have a shot of even at the recommended dosage of NyQuil. You take that, you're probably not going to feel like going out and running a marathon. You're going to be pretty groggy. Barbiturates decrease CNS activity, central nervous system, brain and spinal cord activity. They're used as like sleep aids, and barbiturates can impair your memory conversion from short-term to long-term memory. We'll talk about that more. And can even cause memory loss. Okay. Tranquilizers. These are things like Valium and Xanax. They relieve anxiety and tension and worrisome behavior. They certainly do. But they certainly depress your body and depress your central nervous system as well. Opiates. Opiates are things like heroin and morphine. They give that real euphoric feeling, that real high. They feel awesome. But there's things that they do to your body that are tragic, and there is a price tag physiologically that you pay when you take these chemicals, especially if they're not under the care of a physician. Use of heroin and morphine certainly increases the risk of HIV due to the cultural concept of sharing needles. We've already talked about the three most widely used substances in the United States. Again, that's caffeine, alcohol, and nicotine. You will need to know those. And when we talk about substance abuse disorders that are passed on genetically, it's not that I'm born an alcoholic. That's not what we mean. When we say that alcoholism or substance abuse is passed along genetically, what we mean is it's the normal person who does not have an it relates to impulsivity. Someone who does not have an impulsivity disorder can go out to dinner, they have a glass of wine or a beer or a cocktail or whatever it is, and they say, I've got to drive. It's fine. They're able to say, I'll just have the one drink or two drinks. People with impulsivity or alcoholism disorders, substance abuse related disorders, are unable to do that. Even if they want to stop, they just have to have that one more, so they order one more and it becomes a problem. They're unable to adhere to social protocols or keep themselves healthy or out of trouble with the law. Again, we'll talk about this more when we get into the disorders and therapy chapter. Stimulants. Stimulants do just the opposite of the depressants, obviously. They're going to increase central nervous system activity. These are things like caffeine, nicotine. Yes, nicotine is a stimulant. Amphetamines, cocaine, and MDMA, ecstasy. These are things that kind of excite the system. They increase heart rate, they increase blood pressure, and they're people who are on caffeine, smokers, cocaine, amphetamines, people who are on amphetamines or methamphetamines are really excitable people. Okay, they're not going to do these drugs, and they're not going to usually go right to sleep. Hallucinogens. Hallucinogens are like marijuana, LSD, magic mushrooms, peyote, some of these things. And what they do is they modify perceptual experience. What I feel, what I see, is different than what reality is. I'm seeing everything so blue and or so green, and if you're on an LSD trip, you start seeing things that other people don't see. Okay, so it's my perception of reality is very, very, very distorted. All right, we'll end chapter 4 right there. If you guys have any questions, feel free to email me or send me a message. Good luck on the exam.